Okay, welcome to this explainer. Today we're unpacking psoriasis. Now we're skipping past just the surface level stuff and diving straight into the hard clinical data. We really want to understand exactly what happens when the body literally turns against its own primary barrier. Let's get into it.
So what really causes psoriasis? You know, the physical rash is what we immediately see, but the true nature of this disease, it's actually this incredibly intricate process. It's basically a massive, systemic collision between your genetics and your immune system.
And the scale of this condition is absolutely massive. Global studies show it affects anywhere from 1 to 3% of the entire global population. To put that into perspective, that is tens of millions of people navigating this super complex condition every single day.
To make sense of it all, we've got a clear roadmap for today. We'll start with the reality of psoriasis, then uncover the root causes, look at clinical signs and diagnosis, explore the different phases of the disease, dive into complications beyond the skin, and finally wrap up with treatment and prevention.
Section 1. The reality of psoriasis, more than skin deep.
Right off the bat, we have to recognize that this is fundamentally a chronic, recurring condition. It rarely threatens a patient's life directly, but man, the psychological weight is just immense. Psoriasis can severely impact mental health, it creates real barriers in social interactions, and it drastically lowers a person's overall quality of life. The shame, the discomfort, the constant stress of a flare-up, it means the psychological toll is just as heavy as the physical symptoms we can actually see.
Section 2. Uncovering the root causes, the invisible triggers.
Okay, so while the absolute definitive root cause is still kind of a medical mystery, research heavily points to two main culprits: genetics and immunity. There's this genetic marker, HLA-CW6, and it's found in a staggering 87% of patients. Underneath the surface, what's happening is an immune system misfire. Specifically, it's a Th1 response, where these T lymphocyte immune cells get activated when they shouldn't be. These rogue cells basically hit the fast-forward button on your skin cell production.
But here's the catch. Just having the genetics isn't always enough to cause it. It usually requires a trigger. Understanding what actually wakes up that genetic predisposition is crucial. Psychological stress is a massive one, which makes stress management a literal medical strategy here. Then there's physical trauma to the skin. Clinically, this is called the Kibner phenomenon, where a simple scratch or a surgical scar can actually turn into a brand new psoriatic plaque. Other triggers? Focal infections like strep throat, certain medications like beta blockers and lithium, and even environmental factors like climate changes and alcohol consumption.
Section 3. Clinical signs and diagnosis, the medical detective work.
So how do dermatologists actually identify psoriasis when there are hundreds of other skin diseases out there? Well, let's contrast a healthy skin cycle with psoriasis. Normally, skin cells grow deep down and slowly rise to the surface over about a month, right? They just fall off unnoticed. But remember those hyperactive T lymphocytes we just talked about? They cause psoriatic hyperproliferation. The skin cells rush to the surface in a matter of days instead of weeks. The result is what you see here. Erythematous plaques, these red, inflamed patches covered with thick, overlapping silvery white scales that actually shine almost like mica.
And that brings us to one of the most fascinating diagnostic tools out there, Broke's phenomenon. It's essentially a clinical scraping test. A dermatologist will gently scratch the plaques, sometimes up to 160 times, to observe three highly distinct layers. First up is the candle wax sign, where thin white scales flake off, looking a lot like dried wax. If you keep scraping, you hit the onion scale sign, where you can peel off a thicker, more cohesive layer of skin. And finally, you reach the blood dewdrops, also known as the auspitz sign. Because the blood vessels beneath the plaque are overgrown and pushed right up to the surface, pulling off that very last scale leads to this tiny, pinpoint bleeding. It is a definitive, unmistakable hallmark of the disease.
Section 4. Different phases of psoriasis, visualizing the variants.
Now, psoriasis doesn't look exactly the same on every single patient, and it definitely doesn't present the same way on different parts of the body. Take a look at these two completely different presentations. On one hand, you have classic plaque psoriasis on a patient's back, these large, highly inflamed, scaly patches. But then look at the fingers. Psoriasis can uniquely manifest in the nails, causing this very distinct pitting, thickening, and discoloration. And get this, sometimes nail involvement happens long before any skin lesions even appear, which makes it an absolutely vital clue for doctors.
And things can escalate into even more distinct variants. Look at this severe pustular psoriasis. I mean, it looks pretty alarming, right? It's characterized by these sterile, white pustules sitting on top of bright red skin, and it's often accompanied by high fevers and complete exhaustion. Now contrast that with scalp psoriasis, which is incredibly common, accounting for about half of all cases. It presents with this very thick, layered scaling localized right at the hairline or sometimes covering the entire scalp.
Section 5. Complications beyond the skin. Systemic impact.
Because this disease shows up on the surface of the skin, it's super easy to assume the damage stays on the surface. But that's simply not true. Severe, untreated psoriasis actually attacks the body on a systemic level. A very serious reality here is that between 10 to 25% of patients will eventually suffer from psoriatic arthritis. And as you can see, this isn't just standard joint pain. It is severe, debilitating inflammation that can lead to permanent joint destruction, often going after the fingers and the spine. There's also eczematization. That's a secondary complication where the skin becomes intensely itchy, weepy, and inflamed, quite often because of excessive scratching or using the wrong topical treatments.
Which leads directly into a really crucial clinical warning. As our source material explicitly points out, complications don't just happen from the disease running its natural course, they often happen from non-standard treatments or patients incorrectly self-medicating. A perfect example, the sudden withdrawal of systemic corticosteroids. Patients often misuse these looking for quick, immediate relief, but stopping them suddenly can trigger erythroderma. That is a terrifying, potentially life-threatening condition where nearly the entire surface area of the body becomes intensely red and dangerously inflamed.
Section 6. Treatment and prevention. Fighting back. So with all these risks and cellular misfires happening, how does modern medicine actually fight back? Well, the medical arsenal is vast, but it's highly structured. Doctors generally categorize treatments into 3 main pillars based on how severe the case is. For mild to moderate psoriasis, they start with topical treatments. Things like salicylic acid creams to break down the scales, or calcipotriol, which is a vitamin D derivative that actually slows down cell growth. If that doesn't cut it, they step things up to phototherapy. This uses carefully controlled doses of UVB or UVA light to suppress those overactive immune cells in the skin. And finally, for severe or highly resistant cases, doctors turn to systemic treatments. These are oral medications like methotrexate or retinoids that work throughout the entire body to regulate the immune system and put the brakes on cell proliferation.
But the true cutting-edge science right now, that lies in biologics. These are advanced, lab-created therapies that essentially act like sniper rifles for the immune system. They target highly specific interleukins, like IL-17 and IL-23, or they inhibit TNF-alpha. These are the exact communication molecules that are actually causing the inflammation in the first place. It is a complete game changer. Yet, even alongside this amazing high-tech science, clinical texts constantly stress the need for holistic care. Modifying your lifestyle, limiting alcohol, avoiding physical triggers, those are just as important as the drugs. And above all, psychological support is absolutely vital. You literally cannot effectively treat the skin without also supporting the patient's mind.
Which brings us to our final thought. Today, we've peeled back both the physical and microscopic layers of psoriasis to see it for what it truly is, a complex, systemic, immune-driven disease. But knowing that the mental burden can be just as heavy, if not heavier, than the physical plaques, leaves us with a real question. How can we, both as a society and as individuals, better support the invisible psychological battles fought by patients living with chronic skin conditions every single day? Definitely something to think about. Thank you so much for joining me on this explainer, and as always, keep asking the deep questions.